This is Dr. Thomas Dayspring, Chief Academic Officer at True Health Diagnostics, with a lecture on interpreting LDL biomarkers. This graphic illustrates that the probability that a particle's cholesterol content will be delivered to plaque depends largely on atherogenic particle number, or LDL particle number, since they make up the majority of ApoB containing lipoproteins. Atherogenesis depends how many particles enter the wall, become oxidized, and get ingested by macrophages, turning them into foam cells. Particle number is a crucial biomarker. But let's look closely at how the laboratory evaluates low-density lipoprotein. Of course, LDLs are just one of several lipoproteins that do circulate in plasma. It's an ApoB-containing particle containing a surface of phospholipids, free cholesterol, and a core of predominantly cholesterol ester, but some amount of triglycerides. So LDL per se is not a laboratory test, but there are many assays the lab can perform to give a clinician information that is clinically usable about risk related to low-density lipoproteins. So, of course, counting how many particles circulate in plasma can be done nowadays, and the most commonly used technique is nuclear magnetic resonance spectroscopy. Of course, total LDLP consists of all of the LDL particles regardless of size, as well as any Lp(a) particles that may be present in a liter of plasma. If somebody doesn't have substantial quantities of Lp(a), that's not a contributory to total LDLP. But every LDL particle has a single molecule of apolipoprotein B. Because of its long half-life, the vast majority of ApoB-containing particles are low-density lipoproteins. So the laboratory can perform an ApoB concentration, and it's just another metric that gives a clinician information about the number of LDL particles that are present. To reiterate that point, here's a very interesting study done by Garvey in patients who had no insulin resistance. They were quite insulin sensitive. They had insulin resistance, or they were frank type 2 diabetics. And as you can see, there are the number of VLDL particles that they had. It does increase with insulin resistance in type 2 diabetes, but not tremendously. Let's look at IDL particles. It's almost the same throughout the spectrum of those three disease states. However, let's look at LDL particle concentrations. So you can see of all the ApoB containing particles, the overwhelming vast majority are LDL particles. And yes, LDLP is higher in insulin resistant states than insulin sensitive states, and even higher in frank type 2 diabetics, but it's not tremendously different. So again, the point is ApoB is really an LDL particle count. Back to our graphic. So you can do LDL particle counts using nuclear magnetic resonance. And of course, that includes small LDL particles and Lp(a) particles if there are any present. One can measure ApoB, but one can seek a measurement of LDL size, which can vary from very large to normal size to very small. We all know that small LDLs are more prevalent in insulin-resistant disease states or hypertriglyceridemic disease states, and very large LDL are most commonly seen in those with familial hypercholesterolemia. Again, it's not the size that determines per se atherogenicity, but particle number. The most commonly used metric for the last 50 years, of course, has been LDL cholesterol, the cholesterol content of all the LDLs that circulate in a deciliter of plasma. And it's basically a surrogate of LDL particle counts, or ApoB. It often correlates, but many times it doesn't. And of course, laboratories can provide a measure of the cholesterol content of the small, dense LDL particles, which is a clinically useful tool to ascertain whether insulin resistance is present or not. Of course, the only LDLs that get ingested by arterial wall macrophages are oxidized LDLs, and that is a metric that is available nowadays. So if a clinician is interested in getting information related to LDL particles and to use that in ascertaining risk in a patient, or perhaps to use it as a number at which to initiate various types of therapy, or to use some of these markers as goals of therapy, True Health Diagnostic offers several LDL-related biomarkers. And you see the list on the left. On the right, you see optimal, intermediate, and high-risk concentrations. And we're going to go through how to interpret the numbers that may come back from these various assays. First, I want to discuss by far the most commonly ordered and used LDL biomarker in the world, and that would be a calculated LDL cholesterol. This metric is calculated using something called the Friedewald formula, where one takes total cholesterol, a lab assay, and from it you subtract the combination of HDL cholesterol, another directly measured assay, plus a calculated VLDL cholesterol. And to come up with that number, because laboratories are not directly measuring VLDL cholesterol, one divides triglyceride by 5 on the assumption that all of the triglycerides are in VLDL particles, and the normal composition of a VLDL is 5 times more triglyceride than cholesterol. Understand that the calculated LDL cholesterol includes the cholesterol that are in your intermediate density lipoproteins, maybe some small remnant lipoproteins, all of your LDL particles, be they big or small, and of course, if a patient has it, the cholesterol content of any Lp(a) particles. And the unfortunate variable for this is because triglycerides are involved in the calculation, you must be fasting to do this calculation. And for the most part, triglyceride levels have to be under 150, maximum of 200, for that triglyceride by 5 ratio to have accurate meaning. So this calculated LDL-C must be done in a fasting state and cannot be used in patients with any significant degree of hypertriglyceridemia. True Health Diagnostics offers its clinicians and clients a directly measured LDL cholesterol, which, as the diagram shows, represents the cholesterol content within all of the LDL particles that are present, plus any Lp(a) particles that are present. It does not measure intermediate density lipoprotein cholesterol or any small remnant cholesterol. Because there is no relationship to a triglyceride level, fasting is not required, and this assay can be used in people who have hypertriglyceridemia. The cut points are on the report form, and in general, ApoB containing biomarkers are considered desirable if they're at or below the 20th percentile cut point in a population study, and high risk if they're above the 80th percentile population cut point. So in general, the bottom 20th percentile LDL cholesterol would be 100 or less, and the higher levels would be where risk begins, and those are at the 160, 180 milligrams per deciliter concentration. Of course, we've known from many epidemiological and clinical trials that although LDL cholesterol has a high correlation with cardiovascular risk, there are an awful lot of people with significant coronary disease who do not have seriously abnormal LDL cholesterol levels. And one of the more famous studies is the Get with the Guideline study, which looked at hospitalized patients who were known to have existing coronary artery disease, and they looked at lipid concentrations in 136,000 of them. And as you can see from the LDL cholesterol distribution curve, over 50% of people with coronary artery disease had an LDL cholesterol under 100. Now, some of these may have been on treatment and many were not, but it just goes to show you you can have rather under the 20th percentile LDL cholesterol cut points and still have coronary artery disease. So we're going to need in many patients a better surrogate of LDL particle concentration than is LDL cholesterol. Thus, it is essential to have an understanding of the differences and perhaps similarities between cholesterol measurements and actual lipoprotein particle counts. LDL cholesterol is a lipid concentration metric. ApoB and LDL particle count, or small LDL particle counts, are lipoprotein metrics. Now, in many patients, there's a high correlation between cholesterol content of a particle and particle number. But in many patients, there are not. And as you will see, risk always traffics better with the particle count rather than the cholesterol content. So it's essential to look at both in many people who one would consider might be at risk or has risk. In many patients, there is concordance, the two metrics agree, or there is discordance, meaning one is high and the other low, or vice versa. The multi-ethnic study of atherosclerosis, or MESA, illustrates this point extremely well. Every dot in this graph is an individual patient. So in general, on the x-axis you see LDL cholesterol, and on the y-axis LDL particle concentrations. It looks like in general they correlate very well. And indeed, when both of those metrics are both normal, high, or low, they are said to be concordant, and each adequately predicts risk. When LDL cholesterol and LDL particle counts are not both normal, both high, or both low, they are said to be discordant. For example, let's take an LDL cholesterol level of 100. That's the 20th percentile cut point. And that's usually considered, except for super high-risk persons, a desirable LDL cholesterol level. But we know LDL particle counts are a better determinant of risk. So patients with an LDL cholesterol of 100, some have a 20th percentile LDL particle cut point of 1,000 nanomoles per liter. So the two metrics correlate well, and both would be equally predictive of risk. However, there are some people with an LDL cholesterol of 100 who have incredible low LDL particle counts. That might be a person where you're not happy with an LDL cholesterol of 100 because perhaps they are in a high or very high risk category. But with an LDL particle count of 500 to 600, does one really have to worry about that LDL cholesterol level? Finally, what if your LDL cholesterol is 100 milligrams per deciliter, but you have an LDL particle count of 1,900 or 2,000 nanomoles per liter? And you can say, wow, in that person, risk would be better defined by the LDL particle count rather than LDL cholesterol. And even though you would say an LDL cholesterol of 100 is fine, and an at-risk person, I don't think most of us are willing to be content still looking at an LDL particle count in the 1,900 nanomoles per liter range. This famous slide, using clinical outcome data from the Framingham Offspring trial, looks at what happens when LDL particle count and LDL cholesterol are concordant, they agree, or when they are discordant. And this Kaplan-Meier survival curve is looking at event-free survival among participants based on their LDL cholesterol or LDL particle count. And indeed, when you combine the data for men and women, LDL particle count was twice as strongly related to CVD incidence, as was LDL cholesterol. And look at the two curves there. Of course, you don't want to have a very steep curve because that means increased mortality. You would like the slope of the line to be less. So let's look at the top line where the slope isn't too bad. And notice in red, they both had low LDL particle counts and low LDL cholesterol. Fine. Now look at the green line that has virtually the exact same slope. These people had high LDL cholesterol, above the median value, but they had low LDL particle count. So it's not the LDL cholesterol that determined the slope of the line, but rather LDL particle count. Now let's look at the bottom line, the blue and the gold, which have steep slopes, meaning associated with increased or decreased survival. And again, the blue is high LDL cholesterol, so you'd say, of course, they have worse survival. But the gold or yellow line has low LDL cholesterol. What determines the slope of that more horrific line? It's the LDL particle count. In both cases, they're high. So if you look overall, when the two markers are concordant, they equally predict risk. When they are discordant, the particle number is what drives the cardiovascular risk. And the only way to know whether discordance or concordance is present is to do both biomarkers. Very important data was published by Peter Toth and colleagues in atherosclerosis in 2014. And they looked at a claims analysis that was performed among over 15,000 high-risk patients in a healthcare database. And they could look at the impact of LDL cholesterol levels on risk across cohorts who achieved an LDL particle count less than 1,000 nanomoles per liter or an LDL cholesterol less than 100 milligrams per deciliter. Does it matter if you've attained an LDL-C of 100, what your LDL particle count is? The cohorts were matched to balance demographic and comorbidity differences. The risk of a CHD event increased by 4% for each 100 nanomoles per liter increase in LDL particle concentration. The comparative analysis included over 2,000 matched patients with 12 months of follow-up, over 1,200 with 24 months of follow-up, and 705 with a 3-year follow-up. At all time periods, patients undergoing LDL-P measurements were much more likely to get intensive lipid-lowering therapy and, no surprise, had a lower risk of coronary heart disease stroke than those in the LDL cholesterol cohorts. This would indicate that when clinicians order LDL particle counts, they act on it, even if the LDL cholesterol seemingly is okay. This is the first study to investigate the association between LDL particle count and cardiovascular disease events in a large, real-world environment of commercially insured patients. The results certainly suggest that there is a direct association between increases in LDL particle count and the risk of coronary heart disease after accounting for LDL cholesterol levels, that patients achieving an LDL particle level less than 1,000 nanomoles per liter received more aggressive lipid-lowering therapy than the patients who had achieved an LDL cholesterol less than the same 20th percentile cut point, 100 milligrams per deciliter. And these differences in lipids and therapeutic management were associated with significantly better control of all components of the standard lipid profile and a reduction in cardiovascular disease events, coronary heart disease and stroke over 1, 2, and 3-year periods. Here is the Kaplan-Meier survival curve. So what was the survival in the patients who achieved an LDL cholesterol level of 100 versus those who got their LDL particle count under 1,000 nanomoles per liter? Remember, the steeper the slope, the worse the outcome. And clearly, LDL particle count was getting that to that 20th percentile cut point or lower had a better survivability. So now let's look at what I like to call apolipoprotein B cholesterol, which of course is a somewhat more scientific term for non-HDL cholesterol. It represents the cholesterol that is not in one's high-density lipoproteins. If cholesterol isn't in an HDL, it has to be in an ApoB-containing particle, the vast majority of which are LDLs. But understand, just like LDL cholesterol, in certain patients, non-HDL cholesterol also includes Lp(a) cholesterol. So in essence, non-HDL cholesterol is the cholesterol in your ApoB particles, meaning any chylomicrons that still might be floating around, VLDL particles, IDL particles. Even though there's not a lot of them, they would be your remnant particles, LDL cholesterol, and of course, if present, Lp(a) cholesterol. And many guidelines have recommended, at least as a goal of therapy, that you look beyond LDL cholesterol and get non-HDL cholesterol, or in my terms, ApoB cholesterol. That would call for a more aggressive lifestyle and or, if needed, pharmacologic therapy than whatever it took to get LDL cholesterol to goal. But my question is still going to be, how good is the correlation, or is there any degree of discordance between non-HDL cholesterol and apolipoprotein B? Because if there is, then how could I really, deep down in every person, trust non-HDL cholesterol? So here's very interesting NHANES data. And again, x-axis is non-HDL cholesterol, y-axis is apolipoprotein B, meaning LDL particle counts. And again, it looks like there's a high correlation. There's a rather straight line. The higher the non-HDL cholesterol, the higher or more likely ApoB will also be elevated. But now let's zero in on somebody who's got a non-HDL cholesterol of 150, 160, right in the middle. Not a terribly scary non-HDL cholesterol. What would be the concordance or discordance with respect to apolipoprotein B? Well, you can see, even though non-HDL cholesterol is a better ApoB biomarker than is LDL cholesterol, there can still be significant discordance. So at that borderline non-HDL cholesterol level, one might have an ApoB of 130 and 135, that's virtually FH type levels, or one could have an incredible apolipoprotein B below 90. So if you tell me what a patient's non-HDL cholesterol level is, how can I know with any degree of certainty what the particle number would be unless I measure the ApoB or LDL particle number? This slide takes that NHANES data a little further because this is a clinical trial called the Collaborative Atorvastatin Diabetes Study. So in diabetics, they wanted to look at concordance or discordance between non-HDL cholesterol and apolipoprotein B. And as you can see, in many patients, look at the yellow bar, they either were both high or they were both normal. In other words, they were concordant, and they would equally predict risk. But let's look at the upper left quadrant there. Look how many people had normal LDL cholesterol, as evidenced by the vertical check mark, compared to abnormal, as indicated by the big X, apolipoprotein B levels. In the lower right-hand box, notice that there were very, very few people who had a normal ApoB who had an elevated non-HDL cholesterol level. So again, this would indicate that on statin therapy, be careful believing everybody with a wonderful non-HDL cholesterol level also has a wonderful apolipoprotein B level. In 2016, we got some powerful data from the coronary artery risk development in young adults, better known as the Cardia study. And this was published in the Journal of the American College of Cardiology. And the study group included over 3,000 non-pregnant women and men recruited between the ages of 18 and 30, so young people, and they had ApoB measurements at baseline. And then 25 years later, they got coronary calcium scores, which, as you know, would establish the presence of coronary atherosclerosis. And they could look back and see, look at conventional lipid concentrations and look at apolipoprotein B, and could you, at baseline, when a person is young, get a handle on who is more likely to develop coronary atherosclerosis? And so they looked at when these measurements correlated and when they were discordant, meaning they did not correlate, and some very interesting data. So across the top, people were separated into 4 groups. Those that had both low apolipoprotein B LDL cholesterol and non-HDL cholesterol, those who had low apolipoprotein B concentrations but elevated LDL cholesterol and non-HDL cholesterol concentrations, those who had high apolipoprotein B, atherogenic particle number, and low LDL cholesterol and non-HDL cholesterol levels, and then looked at those who had both high apolipoprotein B as well as high LDL cholesterol and non-HDL cholesterol metrics. And there are some graphic representation showing you what types of lipoproteins may explain the correlation or the discordance. But bottom line is, what were the outcomes? Who had low risk for developing coronary calcium, who had high risk? So if you look at column 1 on the left, the people who had both low apolipoprotein B as well as low cholesterol measurements, meaning LDL cholesterol and non-HDL cholesterol, had the lowest risk, the lowest chance of developing a positive coronary calcium. Now go to the quartile on the right, who, of course, had the highest risk for developing a positive coronary calcium score. And no surprise, they had both high apolipoprotein B and high LDL cholesterol and non-HDL cholesterol levels. So, of course, on the left, the 2 markers were concordant, and on the right, they were also concordant. Now let's look at the 2 middle sections where the measures were discordant. So, column 2, second from the left, the apolipoprotein B was low, but the LDL cholesterol and the non-HDL cholesterol were elevated. These people had low risk for developing a positive coronary calcium despite their elevated non-HDL cholesterol. And look at the second group from the right, where apolipoprotein B was high, but LDL cholesterol and non-HDL cholesterol were just fine. They had high risk for developing a positive coronary calcium score. And how would one explain a high ApoB in the face of low LDL cholesterol and non-HDL cholesterol? These people have cholesterol-depleted particles, so it takes a lot more ApoB-containing particles, the vast majority of which are LDLs, to traffic that amount of LDL or non-HDL cholesterol. Bottom line, this study adds to the growing body of literature by demonstrating similar results across the early adult life course, suggesting that measuring ApoB as a marker of lipid-associated atherogenic risk may help identify young adults at risk for midlife coronary artery disease, decades before the adverse levels of traditional risk factors manifest. And clearly, this can provide opportunities for earlier intervention with lifestyle or, if needed, medication in these people. This should be a familiar slide, but I just wanted to reiterate what the population percentile cut points are using the various biomarkers, the LDL biomarkers on the left, LDL cholesterol, non-HDL cholesterol, ApoB, and LDL particle count. And these numbers come from 2 major epidemiologic trials, as you can see. And we have 20th percentile cut points, theoretically desirable. Or we have the 80th percentile cut points, which would be considered high risk. And the 5th percentile cut points are shown because in the people with the most extreme or highest cardiovascular risk, many clients or clinicians strive to really drop the atherogenic lipoprotein load, and those would be the values that might predict whether you're there or not. So when these biomarkers say are all in the 20th percentile cut point or all in the 80th percentile cut point, they correlate. They're all equally usable. However, when one is perhaps in a low population cut point and the other is the high, the risk travels with ApoB or LDL particle counts better than it does with the risk predicted by non-HDL cholesterol or LDL cholesterol. Keep in mind, non-HDL cholesterol is not a particle concentration. It's a guesstimate of ApoB or LDL particle count. Perhaps a better guesstimate than is LDL cholesterol, but from some of the graphics I've shown you, you just never know in an individual patient. Several cardiovascular organizations have guidelines or statements that have shown what population percentile cut points are for LDL cholesterol, ApoB, and LDL particle counts, and where risk is best related. These guidelines can help one position risk determination and perhaps goal of therapy. This does not mean that any of these organizations are per se advocating that you do particle counts, but they discuss them. So these biomarkers are hardly experimental. The data has been around for a long time, and more people are taking them very seriously. True Health, of course, in addition to ApoB, LDL particle counts, and cholesterol assays, can take it a step further. And two LDL biomarkers that are offered are small LDL particle count, which is part of the total LDL particle count, and most recognize that small LDL particles are likely to be more prevalent in insulin-resistant patients or type 2 diabetics or hypertriglyceridemic patients. Whereas small LDL cholesterol is not a particle count, but rather refers to the cholesterol content of all of the small LDL particles that exist per deciliter of plasma. And of course, the more small LDL particles there are, the more likely one is to have an elevated small, dense LDL cholesterol concentration. The biggest use, especially early in the game for small LDL particle counts and small, dense LDL cholesterol, is to use them as lipoprotein biomarkers or lipid biomarkers indicative of the likely presence of insulin resistance. There is published data in the MESA study looking at the distribution of small LDL particle concentrations across the entire population, and it's sort of a bimodal distribution, with the majority of people having rather unremarkable levels defined as less than 200 nanomoles per liter. But as you can see, there are substantial numbers of people in our population who do have significant elevations of small LDL particles. And remember, the desirable total LDL particle concentration is less than 1,000 nanomoles per liter, and small LDL is only one contributor to the total LDL particle count. So in these people who are in the hump that's to the right, the odds are very good that not only is their small LDL particle concentration elevated, but their total LDL particle concentration is elevated. And these are most likely to have insulin resistance or type 2 diabetes. Looking at a study done by Garvey, where he wanted to characterize the type of lipoproteins that are present in both insulin resistant and type 2 diabetics, as opposed to those people with normal insulin sensitivity, you can see there's a big jump in the small LDL particle counts as one goes from insulin sensitive to insulin resistant to frank type 2 diabetes. In that same study by Garvey, if one looks at the x-axis, glucose disposal rate, and on the y-axis, LDL subclass, meaning small LDL particle concentration, one can clearly see the relationship with insulin resistance and small LDL particles. Here is data from the MESA study with respect to small dense LDL cholesterol measurements and its distribution. It's a bell-shaped curve, as you can see. And the assay used in this is the one that is currently in use at True Health Diagnostics. And they also evaluated or correlated the small dense LDL cholesterol with the NMR-derived small LDL particle concentration. And interestingly, there was only a modest correlation. This study also showed that elevated small dense LDL cholesterol was a risk factor for coronary heart disease in normal glycemic individuals. This would make me think that even though these people didn't have glycemic issues, there likely was some degree of insulin resistance, which perhaps manifested in at least these people as an abnormal small dense LDL cholesterol level. And this is a different way of examining the data from the MESA study, looking at both small LDL particle concentration and small dense LDL cholesterol, where in the normal glycemic patients, the small dense LDL cholesterol was a better predictor than either LDL cholesterol or small LDL particle counts. What we don't see here is if we looked at total LDL particle counts, would small dense LDL cholesterol still have that statistically significant advantage? Nonetheless, I think, again, we're looking here at normal glycemic patients, and it goes to show you that small dense LDL cholesterol can have some importance in risk prediction, and I suspect declaring the presence of some degree of insulin resistance. If you remember some of the earlier discussion, atherogenesis occurs when oxidized LDL particles are ingested by arterial wall macrophages, creating foam cells. Those macrophages, which have scavenger receptors, do not ingest non-oxidized LDL particles. Now, the vast majority of LDL particles undergo complete oxidation within the wall of the artery. There are no fully oxidized particles to any extent circulating in plasma because the plasma is full of many antioxidant factors that don't permit that, and scavenger receptors in various tissues clear any fully oxidized LDL particles rapidly. So when a laboratory is reporting oxidized LDL concentration, they're really reporting the circulating presence of minimally oxidized LDL particles, which indeed are only a tiny fraction of all LDL particles, but their presence in plasma would certainly indicate oxidative forces are at work, or perhaps the patient ingested some oxidized lipid moieties or so. Oxidized LDL concentration is assayed by using specific monoclonal antibodies that attach to the oxidized ApoB moiety on LDL particles. And elevated oxidized LDL levels are associated with, as you might expect, in diseases that have coexisting inflammation and oxidative stress. And to name a few, polycystic ovarian syndrome, rheumatoid arthritis, Alzheimer's disease, diabetes, metabolic syndrome, perhaps other autoimmune diseases. And you can see from the bar graph on the right that there is a nice correlation between oxidized LDL and the presence of coronary artery disease. Now, this is not adjusted for ApoB or LDLP. No one is suggesting that this biomarker replace atherogenic particle numbers, but they're used in conjunction with them to perhaps indicate the presence of oxidative forces which might have a heavy influence on the type of lifestyle one recommends to a patient. Lastly, I want to discuss lipoprotein a. And depicted before you is an Lp(a) particle, which is simply an LDL particle which on its surface contains a single molecule of apolipoprotein A. And that ApoA protein can be a high or large molecular weight or a small or low molecular weight. So many people have two types of ApoA isoforms that attach to their LDL particles. This has a codominant inheritance, so the genes regulating Lp(a) come from both mother and father, and it is highly associated with increased cardiovascular risk. True Health is unique in that it's the only laboratory that provides an actual Lp(a) particle concentration. Most laboratories report Lp(a) mass, which we'll talk about in a second. And what True Health does is it separates lipoproteins by electrophoresis, and then looking at the Lp(a) band of the lipoprotein distribution has a marker that picks out ApoB. So it's really an Lp(a) ApoB particle number, but there's one ApoB on every Lp(a), so it gives you a pretty accurate number of Lp(a) particles. Other labs measure mass, which is basically weighing everything that's in an Lp(a) particle, including apolipoprotein A, but way beyond that. And here you go. There are the components that are measured when one orders an Lp(a) mass test. It is the collective molecular weight of all of the blue triglyceride molecules, dark brown curve apolipoprotein B molecules, yellow with a red tail cholesterol ester molecules, the little brown dots with two legs, phospholipid concentrations, and of course the different types of ApoA isoforms that might be present, big and small. So lipoprotein A mass has multiple determinants that gives you the final number, as opposed to Lp(a) particle counts, which is just telling you not the size of the Lp(a), not the isoform of Lp(a), but how many Lp(a) particles are present. We certainly know with respect to LDL particles and HDL particles, a particle metric is more informative than our component or cholesterol or lipid measurements. And the hypothesis is that that same strategy would apply to Lp(a) particle counts. This is some interesting data that is in a recent incredible review by Sam Semikis of Lp(a) and Lp(a) testing. And how bad is Lp(a) as a cardiovascular risk factor? Whether you use meta-analysis data looking at Lp(a) mass concentrations in the far left, where there's clearly a relationship with risk once you cross a certain threshold of somewhere above 30 milligrams per deciliter of Lp(a) mass, or whether you use Mendelian randomization trials, which pretty much imply causality, the risk can be horrific at increased levels. And interesting on the right, where it shows the allele variant number matters. And for those who have two variant alleles, likely will have the highest Lp(a) mass concentration, the risk is highest. This is a very interesting analysis comparing Lp(a) particle number versus Lp(a) mass. Now across the bottom you see Lp(a) mass. From left to right, increased concentrations. But on the y-axis you have Lp(a) particle numbers. Now we're going to show you lines that are blue, green, and red. The blue would be those who predominantly have the large high molecular weight isoform. And people who have the genes that produce that don't, it's hard to make, it takes hepatocytes longer to make it, and it's tougher to secrete. Whereas red, the low molecular weight, the shorter ApoA isoforms are produced very rapidly in hepatocytes and easily secreted and attached to LP LDL particles, making LP little a. And the green would be those with an in-between molecular weight. So in those with the average molecular weight, clearly as LP little a mass goes up, so does LP little a particle count. In those who have the high molecular weights, yes, in general, as LP little a mass goes up, so does the LP little a particle count, but nowhere near as severely as those with the in-between molecular weight. And let's look at those with the low molecular weight, the short isoform of apo little a, which in many studies has been implicated as perhaps the most atherogenic type of apoprotein little a. And once again, you see as LP little a mass goes up, so does LP little a particle counts, but much, much higher than those with larger molecular weights. This often would raise the hypothesis that it's not so much the apo little a isoform that matters, but the number of LP little a particles, because those with the small isoform have the highest LP little a particle counts, despite whatever their LP little a mass is. And the final bit of important information with respect to lipoprotein little a is even in people aggressively treated with statins or statin niacin, if the LP little a concentration is in the fourth quartile, meaning the elevated levels, despite what the statin or statin niacin has done to other lipid parameters, there is still significant residual risk. So you always, when you're evaluating risk, LP little a adds to a patient's overall cardiovascular risk, irrespective of LDL cholesterol, which you see in at least two of these trials was driven extremely low to 65 in the top trial and 55 in the bottom trial, the Jupiter trial. So just keep it in mind. It's a bad, bad risk factor in those with the highest levels. I thank you very much and appreciate your time for watching and listening to this lecture.